Welcome to the first in our video podcast series here at the Keyhole Heart Clinic, where I really have the privilege and pleasure of introducing to you Mr. Arvind Singh, a heart surgeon at the Essex Cardiothoracic Centre. He has a specialist interest in aortic surgery and particularly very accomplished in the area of aortic valve repair. Today, we're going to ask Arvind about some really complex issues that he knows a great deal about. So I'm really looking forward to this conversation. Arvind, welcome.
Thanks, Inder.
Arvind, tell me, what is the aortic valve?
The heart has four valves, and one of them is aortic valve. And as the name suggests, it is at the origin of aorta. Whenever heart beats, it pumps blood into a blood vessel, which is the biggest blood vessel of our body. It's like a hose pipe arising from the heart, and the aortic valve guards the opening of the left ventricle, which is the main pumping chamber of the heart, and the aorta.
How many leaflets does a normal aortic valve have?
Yeah. Normal aortic valve has three leaflets, and their job is to open and close at the right times to allow the heart to pump the blood into the aorta.
I always liken the aortic valve to the Mercedes sign on the front of Mercedes car.
That's
It's
correct.
very much like that, and the symmetry of the three leaflets
That's
is
correct.
the reason why a three leaflet valve works so well. But of course, we are interested today in bicuspid aortic valves. Tell me about bicuspid aortic valves and why they're important, why they're different.
As the name suggests, they are bicuspid, meaning there are two cusps, meaning instead of three leaflets, there are two leaflets. What we are discussing here is developmental anomaly where a patient is born with two leaflet instead of a three leaflet valve. Most common mechanism of this is that uh, two neighboring leaflets, any two neighboring leaflets of the three leaflet valve, they don't separate while the patient is actually developing in their mother's womb. And they are then born with two leaflets instead of three leaflet valves.
Very interesting. Are bicuspid two leaflet valves more prone to disease?
They are more prone to disease as compared to three leaflet valve. However, just because they are two leaflet valves doesn't mean that they are going to create problem in patient's lifetime. Meaning a number of bileaflet valves may function perfectly normally throughout a patient's lifetime.
So, I mean, I've treated bicuspid aortic valves like you've treated bicuspid aortic valves, and we often see them at the time they've developed disease. They're either calcified and become stenotic
Yeah.
or they leak. Why are they more prone to developing calcific aortic stenosis or aortic valve regurgitation, aortic valve leak?
Let's focus on the stenosis first. And as you can imagine, you very nicely described the Mercedes-Benz, how the three leaflets are quite symmetrical. And by the nature of that particular anatomy, the shear stress on the valve leaflets is almost insignificant. Whereas the moment the anatomy of these valves they change, the shear stress on this particular valve with the normal beating and the normal passage of blood across the valve, it changes. And I think that makes them quite susceptible to early degeneration and therefore early calcification, which leads to stenosis.
And they can leak as well.
They can leak as well. And again, the mechanism is purely related to how these leaflets come together at following a heartbeat. And like the purpose of any valve, they should close completely so that the blood flow is forward flow. In this case, they don't come together properly, and sometimes it is related, or a number of times actually, it is related to the fact that bileaflet valves can be associated with aneurysms or enlargement of what we call the annulus of the valve, meaning where the valves are actually hinged onto the aorta. That particular, if I may call it, annulus or ring, that particular area, it dilates, it becomes abnormal shape, and it doesn't allow the valve to close completely, which is when they start leaking.
So bicuspid aortic valves have a weakness in their actual structure that can mean they can become floppy, or
Correct.
sometimes the actual ring upon which the valve is hanging
Yeah.
within the aorta dilates, separates the leaflets, and makes the valve leak.
It doesn't let them come together. Yeah.
Yeah. And now you made a very important comment there about the aorta and the associated aortic aneurysm of the aortic root that can occur with patients who have bicuspid valve
Yes.
disease. Tell me more about that.
Um, the aneurysms of the aorta basically means the aorta itself is dilated. The caliber of the aorta is more than what it should be. And the risk in these situations is primarily that they will keep on dilating further to a point where they will be susceptible for rupture or something called aortic dissection, because of which it becomes an important association. Why it happens? There are several theories. Two of them are most common. One is supposed to be developmental. So the reason for which the two leaflets didn't separate properly is because there's something in the tissue structure which didn't allow them to separate. And similar thing is actually affecting the wall of the aorta as well. And then being developmental, these kind of situations are associated with aneurysms literally just above the valve, which is the area we call the sinus or the aortic root. The second theory is that because of the flow dynamics across this valve, like you described, the Mercedes-Benz sign, where everything is flowing without any major change in the dynamics of the blood flow, the shear stress being low. Whereas in a bicuspid valve, the opening of the valve changes its shape, one may say that. It becomes more like a fish mouth opening, and the jet coming out from the aorta then starts hitting the aorta, um, and then it causes dilatation of the aorta. Now, this dilatation is usually not associated with the root. It is associated a little beyond, which is called the ascending aorta. So these are the two types of aneurysms which are associated with the bicuspid valve.
So you talked there about something I call eddy currents,
Correct.
which can happen in any abnormally configured valve, more so with a bicuspid than a trileaflet,
Yeah.
but also in valve disease. And that, you say, can create these strange phenomena in the ascending aorta, the early part of this great big hose pipe
Yeah.
in the body, that then can cause it to dilate. And in patients with bicuspid aortic valve disease, there's a predisposing weakness in the aortic root, which can therefore then create aortic enlargement.
Yeah.
Correct?
Yes.
So, one of the biggest dilemmas that we as surgeons have, because the guidelines keep changing, is to know when a patient who has bicuspid aortic valve disease that needs to be treated surgically, either because it is stenotic or it's because it's leaking badly and creating secondary problems within the heart. The question is, when should we also be considering operating on the aortic root to prevent future dilatation of the aorta in this patient?
Like you said, there has been uh, good knowledge about this association. However, the guidelines were slightly unclear up until literally a few weeks ago. The end of February, we've got new guidelines which have been released. These are the European guidelines for aortic aneurysms and diseases of the aorta. And there's a very clear guideline mentioning in these in this publication that patients who have a two leaflet aortic valve or a bicuspid aortic valve who are to undergo an operation for the bicuspid aortic valve, the ascending aorta or the aortic root needs to be addressed if the aorta is more than 4.5, and in some individuals, even if it's less than 4.5, if it's associated with some risky, high risk features. So, in general, 4.5 is the cutoff for addressing the aorta as well as the aortic valve simultaneously at the same operation. Younger the patient, you are thinking more in terms of my patient has a significant amount of long life still left. Let's say we are treating a patient who is in their 30s and 40s, then you will have to customize the operation to the patient. And the guidelines have now mentioned that think about addressing this aorta at a lower caliber. Patients who are small stature, so one can imagine 4.5 can't just be a guideline for somebody who is, let's say, 150 centimeters, short stature, diminutive person, whereas you might be treating somebody who is 6 feet, 180, 185 centimeters height. And the guidelines have now addressed that in a patient less than 1.6 meters height or 160 centimeters, we need to think of lower thresholds in patients with this. The other added thing that the guidelines have said in this recent publication is that you should also consider the length of the aorta, ascending aorta, which was never mentioned in the previous guidelines. So if you are able to measure the length of the ascending aorta from the valve up to the first branch that supplies blood to the right upper limb and the right side of the brain, which is called brachiocephalic artery, if that length is more than 11 centimeters, you need to start thinking of doing something to the aorta at the same time. This is, of course, in addition to other high risk features. If our bicuspid valve patient suffers from hypertension, if there is a family history of aortic problems, if the patient has had an aortic aneurysm operated in some other areas like abdominal aneurysm, then they become high risk patients. And at these situations, you have to start thinking of lowering the threshold. And this is what the guidelines have come up with, the recent guidelines have mentioned.
And what about genetic testing here?
I was going to come to that. Genetic testing is, of course, extremely important in these individuals. So, as far as bicuspid valve per se is concerned, there is no separate genetic testing. However, patients with bicuspid valve can also have what we call connective tissue disorders, like Marfan's and Ehlers-Danlos and Louis-Dietz. These are some of the complex aortic connective tissue disorders. And these are the disorders which one should look for in younger patients, as well as in the families. Primarily speaking, in a bicuspid aortic valve, what one would like to do is also check whether the first degree relatives of the patient also are born with a bicuspid valve or not, so that at least you can in future keep an eye on what's happening with their valve. Their valve may function perfectly normally throughout their life. The aorta may remain completely normal throughout their life, but we know that they would be susceptible for this. So we would be able to keep an eye on this in future.
We've talked about patients who have got bicuspid aortic valve configuration and it's diseased. So clear indication for surgery to the valve. We've talked about the size of the aorta we would consider replacing. We've suggested that 4.5 is a cutoff. Size of the patient matters, and in other risk factors, we might even go as low as 4.
Yes.
Length of aorta is important. What about a patient who has got a normal trileaflet valve and develops an aortic aneurysm? What size might we consider having to operate on that aortic aneurysm? And also, bicuspid aortic valve and what different size we would consider as requiring an operation in that setting. Normal valve, bicuspid, trileaflet, aorta's enlarged.
So you're right. I mean, these are actually two different pathologies in the sense that aortic valve may have an indication for an operation per se, or the aorta may have an indication for operation per se. We are now discussing that probably the trileaflet aortic valve or a two-leaflet aortic valve, they are functioning okay. However, the aorta is enlarged. However, there is an aortic aneurysm. For a trileaflet aortic valve, the guidelines remain the same as they have for almost 2 decades now, which is a threshold of 5.5 centimeters. However, in patients with connective tissue disorders like Marfan's and the others that I had mentioned, Ehlers-Danlos, there is a thought that you have to actually go down as far as threshold is concerned. So you'll probably perform an operation when the threshold, when the aorta is 5 centimeters in these patients. In a center where you perform lots of aortic operations and where your outcomes are quite good, and in patients who are otherwise low risk, the new guidelines have said, don't wait for 5.5. You should actually actively consider thinking of doing their operations at 5 centimeters. This is new. Previous guidelines said 5.5. Now they have said, if the outcomes are good, patients are low risk, and then you should intervene at an earlier stage. Let's now go to the two-leaflet valve. A normally functioning two-leaflet valve or a bicuspid valve, the guideline have now said anything more than 5 centimeters, you should consider performing operation on the aorta as well. And then associated with high-risk features, there's a possibility that you may have to intervene much before that. So newer guidelines are obviously a bit more specific, and they're thinking more in terms of preventing problems like further dilatation and dissection, like taking the patient for an emergency surgery rather than, you could have done it much before when the patient was so well and could have recovered from this.
So it seems to me that the new guidelines, and this is certainly the way that I've interpreted them, is suggesting a much more aggressive stance, whether it's a three-leaflet valve or a two-leaflet valve, on treating enlarged aortas. And the first thing that comes to my mind is that we are naturally going to see more patients who might require intervention on their aorta when their actual aortic valve is maybe structurally completely normal and functioning normally, or perhaps might be functioning abnormally because the leaflets are stretched, but in some manner could be made to work more effectively again if the aorta was addressed. We're talking about here now increasing the likelihood that we may need to be performing operations on patients where we need to preserve aortic valves in the setting of replacing aortas properly. Aortic valve preservation in aortic root replacement. Tell me about this procedure.
So the things that you mentioned just now raise two questions primarily. One is the threshold for actually performing operation for the aorta. And I would like to come in here to say, if you are going in to perform any other heart operation, which does not involve operating on the aortic valve or the aorta, say, for example, you were going to perform a bypass grafts on a patient, or you were to perform operation on other valve like mitral valve in a patient. The guideline now has become, like you said, the guideline has become more aggressive. That's the right word to describe them. The guideline now says, in these patients, you need to address the aorta when the aorta is 5 centimeters. In the past, they would say 5.5 centimeters. Now they're very clear that at 5 centimeters, you need to, if you are going in to perform a non-aortic operation, then you will need to address the aorta if it's 5 centimeters or more, which is different from what they said before. Coming to the second part of your question about valve preservation, this is, according to me, extremely important. We work together in Essex Cardiothoracic Center, and I made it a mission of my life in some ways that an aortic valve which is not calcified should be repairable most often. Not always, but most often. And the most important part of this is we started actively thinking that we want to leave our patient with their own valve, with their natural valve, which is much, much better than any kind of an artificial valve, be it a mechanical valve or a valve made from animal tissues or what we call biological valve. So this is in some ways a newer operation. in the sense that uh, some centers in the world, they pioneered um, developing the exact guidelines, exact steps, uh, exact methodology of or techniques of preserving the aortic valve, whether the valve is functioning properly along with an aneurysm, or if the valve is leaking significantly. And the leak could be something that we class as mild to something that we class as severe. And I'm very glad to see that the last two guidelines, both American as well as the European guidelines, have very clearly stated now that if in context of an aortic aneurysm, the valve is functioning fine, whether it is a two leaflet or a three leaflet valve, both valves could be preserved, essentially replacing the aorta right from the bottom and then resuspending the whole valve within the new aorta that we create. And what's again very important is the guidelines for the severe aortic regurgitation, or simply meaning if the aortic valve is leaking significantly, they have said one needs to actively think whether the valve can be repaired or not. That is a second statement in the guideline where they say that an effort should be made to preserve the valve if the center is experienced. And I think this is extremely important in terms of how the patient is managed in their lifetime.
I mean, we know what the benefits are. We've performed aortic valve preserving aortic root replacements for many years, and we've performed them together through minimally invasive
Yes.
incisions. We see the benefits. But for the sake of the audience, what are the big benefits of repairing the patient's own valve or preserving the patient's own valve? We talked about durability, but what about the way it functions?
So one of the important things to realize is the best engineer for all of us human beings is the nature.
Mhm.
And if nature has provided us with a valve which is functioning fine, or the valve which can actually be made to function like normal, then it's intuitive. Nature is a better engineer than all of us. And therefore, if you preserve a natural thing, then it is going to work much better. In context of the aortic valve, how does it function better? One of the important things to realize is any valve replacement, be it a mechanical valve or a tissue valve, is something which is going within the flow. It is being implanted. It's a foreign body that is going inside the flow. So, come what may, that particular valve has more effect on the currents around, how the blood flows, and also for the blood to interact with this. So when we talk of mechanical valve, a patient goes on warfarin for life, which means one blood test every week, and blood thinning. The thinning can go off in both ways. The blood can become too thick. In that case, patients need extra injections. The blood can become too thin. Patient becomes more susceptible to bleeding. So all their life, they need to be able to manage warfarin. It's very easy in a clinic to say you will go on warfarin. Warfarin is blood thinner. But let's imagine a patient who is 30 or 40 years of age. He's got a long life to live. And we do not know what we are going to suffer from in future. Let's say the patient 20 years down the line suffers from, God forbid, a malignancy or a cancer somewhere, which leads to some sort of bleeding. Now imagine what's going to happen to this patient with a mechanical valve and on warfarin that can't be stopped. On a different note, let's think the patient says, okay, I don't want warfarin. I want a biological valve. At the moment, we do not have a biological valve, which is good for life. All biological valves are going to, at some point, degenerate. They are animal tissues. They were not meant to be in human circulation.
Mm.
So these tissues are not going to sustain the whole life of the patient, which means the patient is going to need another intervention. Now compare these two things to a preserved natural aortic valve. A 35-year-old patient, let's say, has a normally functioning or even a leaking aortic valve, whether it's two leaflet or three leaflet. not calcified. And at the end of having replaced the root and the ascending aorta, if the patient is left with a normally functioning aortic valve, then you have put the patient into the natural history of a normal three leaflet or a two leaflet valve. So, whereas when you give a artificial valve to the patient, you have in some ways given an aortic disease to the patient. Whereas in this patient, and you may be forced to do that in situations where the valve is calcified. There is no other way of creating a competent aortic valve. But in patients where you can preserve the aortic valve, you've actually left the patient with their own valve, which may not require anything to be done during the patient's lifespan. Another most important evidence that is coming out, and hopefully another 10 to 20 years will make it clear, is all the propensity match data is suggesting that the life expectancy of a patient who is left with their own valve is as close to normal population. Whereas a patient who has a replaced aortic valve, whether it's a bileaflet or whether it's a mechanical valve or a tissue valve, their lifespan actually decreases. So I think these are the major advantages of leaving the patient, almost going in line with what we have encountered with a mitral valve. And we established that almost 20 years ago, where we said, whenever we can, we should repair mitral valve. Now, it took a long time to convince the whole surgical fraternity to say, yes, this is what one should do. But that's a norm now. And I'm expecting that is what's going to happen with the aortic valve in another 10 to 20 years.
Preserving a patient's own aortic valve, if done well, leads to better durability, better
Absolutely.
hemodynamics. A lot of patients don't always understand that when we replace the aortic valve, we're literally putting a polo mint sized valve, maybe a bit bigger than a polo mint, into a tube. So we're
Yes.
narrowing the outflow tract. And
Absolutely.
in a patient with aortic stenosis, we may have relieved the blockage, but there's still some blockage. In a
Yes.
patient with aortic regurgitation, we create a blockage. And I think this might be why patients with aortic regurgitation just require a little extra helping hand after their surgery, because we've gone from a heart that's swollen because of the leak, and now this swollen heart, which will recover with time, is having to pump through a degree of blockage because of
Yes.
this foreign body in the way.
Yes.
And I think that's critical. Tell me about aortic valve repair in the context of risk of infection.
Yeah, that's an important point you bring up, because risk of infection is in some ways directly proportional to anything foreign that goes inside our body. As far as heart is concerned, most often it's the valve. And then if you think of aorta, then it's the graft that we use to replace the aorta. In patients where we are able to preserve the valve, the one important prosthetic material that hasn't gone in is the aortic valve itself. Yes, there is a prosthetic material, which is the aorta itself has been replaced. However, and we do not have definite evidence about what is the incidence of infection of the aorta when it's replaced. However, from our practice, we see that very rarely we get aortic replacements coming back to us with infection. Most common infected foreign material that we have to operate on is actually the replaced aortic valves. So you're very right. The risk of what we call endocarditis of the prosthetic material or a foreign material that goes in should be much less in patients where we preserve their aortic valves.
Tell me about the young patient whose aortic valve cannot be repaired. Let's say a patient in their 30s, and they absolutely do not want a mechanical valve. They don't want to take blood thinner. What options do we have for patients like this?
So there are basically two options in this situation. I'll first talk about the commoner option that is being practiced all over, and which is obviously patient doesn't want a mechanical valve, surgeon is well trained in performing valve replacement, So we choose a tissue valve or a biological valve. The available option in the biological valves, we currently have a choice of a potentially long durability option of some newer valves which have been where the animal tissue has actually been treated specifically with the idea that they will not degenerate quickly, they will not calcify uh, as quickly as the previous iterations of these valves, which have been around for about 50 years. We know in younger patients, they will degenerate by about 10, 12 years. But in a 30-year-old or a 35-year-old, 10, 12 years is not enough. And I say potentially because these valves have been around for about 7 years now. And we do not have a 30-year data to be able to say we have used this in human beings and this is our
Now
outcome.
we're talking here about Inspirus Resilium and
Resilience,
Avillus.
correct, correct. These are newer valves, and only time will tell. Although the lab data does show that they last significantly longer heartbeat cycles, because that's what is replicated in the lab, but not for so many years, but within a short period of time.
Are there any more durable options than tissue valves or these new pericardial valves?
Yes, so that was the second thing that I was going to talk about, and that is called as Ross procedure. Extremely specialized procedure, if I may say so. What is done in Ross procedure is patient's own pulmonary valve, like we have an aortic valve at the beginning of the aorta. Similarly, we have a pulmonary valve, which is at the beginning of the pulmonary artery or the artery that goes to lung from the right ventricle. And the idea here is to harvest patient's own pulmonary valve as well as the root and implant it in the aortic position and use some options available for creating a valve at the pulmonary position. This was an operation pioneered by Mr. Ross, who was actually a surgeon in London, and he devised this operation. Technically, it was more challenging, so it never became a commonplace or a regular operation. However, in the last 10 years or so, I must say, there have been some recent interest. Some of the surgeons have, in some ways, I would like to use the term re-pioneered this operation. And the evidence coming out is overwhelmingly in favor of this operation. And again, the propensity match data suggests that these patients will have a normal lifespan as compared to patients who undergo valve replacements. And obviously, all the advantages that we talked about when we talked about preserving patients' own aortic valves are there for this option.
A lot of my patients who come to me that are young and they don't want mechanical valves, they feel somewhat apprehensive about the complex nature of Ross procedure. And I think that even in expert hands, there is a higher potential risk for difficulties. But also, I think that even patients who have undergone Ross procedures still face reoperative interventions of various types, either to the pulmonary valve, which is usually pretty straightforward, but not always so, but also to the Ross replacement in the aortic position. What do you think about that?
So we touched upon two aspects or three aspects here. One is the complexity of the operation itself. And like any other complex heart operation, it would require good mentoring, good training, and of course, to be able to reach that level of expertise, it will require time and a lot of hard work, obviously. However, the outcomes of the operations in the expert hands are, in terms of uh, purely related to, say, complexity of the operation, which basically means how long the patient will take to recover from the operation and what are the immediate mortality and morbidities associated with the operation are actually as good as aortic valve replacements. So if we are able to train people to that standard, then the outcomes, short-term outcomes, should not be an issue for Ross procedure. And you touched upon what's going to happen to both the valves. Let's concentrate on the aortic valve for now. When Ross procedure was started, and when there was initial follow-up in terms of operating on younger patients, some technical issues were identified as reason for these valves ended up with leakage in future. Most of the recent surgeons, they have addressed that issue. So in the current technique of Ross procedure, there is a fair amount of diligence to try and prevent this form of leak of the pulmonary valve in the aortic position. So again, that is not the reason nowadays for patients requiring another operation in their lifetime. Yes, it's what we use for the pulmonary position is something that will require reintervention within patient's lifetime. And two things have come up very clearly in this about, again, in expert hands, about at about 12 years, 13 years, we have evidence that more than 91, 92% of patients will not require a reoperation, either for the aortic valve or for the pulmonary valve. Again, for a younger patient, it's still a short duration. So we're looking at, let's say, 20 years or 30 years down the line. What's going to happen to these pulmonary valves? And I think there are going to be two options for that. One, obviously, surgical, but the second option is going to be the wire-based or the cath lab-based procedures, where we have seen so much increase and so much innovation that there's a likelihood that we will have a solution for that, for the pulmonary valve in Ross procedure. Let's think of surgery for the pulmonary valve in Ross procedure. Even with the surgical procedure or necessary second surgical procedure for the pulmonary valve, the overall outcome for Ross procedure is still very good. So despite the fact that patients require another operation, they actually end up living longer as compared to where you have replaced the valve. That data is also coming up gradually. So again, I think I know we always go back towards mitral valve when we talk of all these logics, but we know that when we repair a valve, and if the repair fails, let's say 20 years down the line, and then we maybe re-repair or replace the valve, those patients still live longer as compared to patients where you would have replaced the valve straight away. So on the same lines, if a Ross procedure patient does require another procedure for his pulmonary valve, still the likelihood is his lifespan is going to be better than if we would have just replaced the valve in the first instance.
I met a patient recently who was in his early 30s with a young child with severe aortic valve regurgitation and no aortic enlargement at that point in time. Genetic history negative, and he opted to have the simpler procedure. He was offered Ross procedure, he was offered xenograft route, he was offered, which is a pig's valve and aorta placed into the ascending aortic position, which arguably has better durability than pigs and cows' valves.
Yeah.
He was offered aortic valve repair in the context of a normal aorta. I'm not entirely sure that his valve was repairable, so I felt that was lowest on the list. And he actually opted for the simple option of a minimally invasive incision through the ribs on the right hand side, which preserved his breastbone, simply replaces aortic valve with one of the new pericardial valves and monitoring of his aorta to see if it enlarges or not, and raised other options for himself in the future, which included TAVI and valve, or included reoperative intervention, which in my view would have been relatively simple because we haven't broken his breastbone at early life, so that when he's older, he's still going to face a simple operation. So I think that what I've found is that actually, as we have more strategies for treating patients with aortic valve disease, it becomes very much more complicated explaining to patients what the various options might be.
Correct.
What do you think about that? And how do you think we could address it? Do we need specialist MDTs that discuss these patients where we have expertise in all these areas in the room so that we can actually hone in the right treatment for each individual based upon what we think is best evidence base, but also includes, and I think this is important, includes patient preference?
Absolutely. So, like you said, your patient um, chose a minimally invasive aortic valve replacement, and I had exactly similar patients in their late 30s, and um, um, he chose the same minimally invasive aortic valve replacement with a biological valve with a potential long-term durability. And when and if that valve degenerates in future, there is an option of going through the groin with what we call TAVI or transcatheter procedure. And I think what's very important is that we put everything on the table in front of the patient. I think one thing one should not do is not tell the patient that there is an option of Ross procedure, because more and more evidence is coming out that it might be perhaps the best option, right? Although it's very difficult to use the best when you have so many options available. And like you said, I think the most important person in that room is going to be the patient, and what they are comfortable with is again the most important thing. Many a times patients come, I'm pretty sure you have seen similar patients where they say, look, I don't want an option of something else to be done in future. You know what? Do a minimally invasive mechanical valve replacement and I will deal with warfarin in my lifetime, right? And again, what you have done is you have put everything in front of the patient and then let the patient choose what they want. I think that's most important. Obviously, the consultation becomes very long as compared to what used to happen 20 years ago when the surgeon would say, you need valve replacement. Thank you very much. I'll see you when the operation is done, right? No longer like that. No, most often my clinic letters go for 2 or 3 pages because in situations, just imagine where they need a valve procedure and the aortic procedure, the amount of discussion that I would be having is enormous. And at the end of the discussion, I say to them, you don't have to decide now. You should go home. My letter will mention everything that we have discussed. So there are prompts for you to think about, and then you make a decision, come back to us within a reasonable time frame so that we can treat you. MDT is very important because obviously you get multiple heads coming together to think about what would be the best option for the patient. And MDT is something that MDT decision is something that you can then offer to the patient. But finally, it is going to be the patient who's going to decide. Our MDT might say that, yeah, preserve the valve, do a repair. But if the patient says, I don't want any chance of failure, because one will have to counsel them about failure of repair as well. And the patient, if the patient comes back saying, I don't want any chance of failure, then obviously you're going to do what the patient asks for. So MDT in that context, to be able to offer probably the best option for the patient, but the final choice is going to be patient's.
I think you've touched on something that's really very important, and I see this all the time. And I've probably been guilty of it too. I think we all have. But I think surgeons have to move away from what they know they're able to do and actually move back and say, look, what is possible for this patient? So the patient actually gets to know exactly what you said, the full spectrum of options that might be available, a guidance on the evidence base that indicates this. And I think a perfect example is minimally invasive. We now know, and there's a nice guidance that suggests this, that in mitral valve disease, if a patient is suitable for minimally invasive surgery, that patient should be referred to a center of expertise if local expertise does not exist. I still face the same issue with patients coming to the Keyhole Heart Clinic who say, well, my surgeon told me my valve is not repairable. And this is a simple posterior leaflet rupture that we've been repairing for the last 20 years. And actually, as surgeons across the world, we've been repairing through minimally invasive incisions for more than 30 years. I think the same applies to everything. We as surgeons need to concentrate more on the patient, be a lot more patient centric, and use what we understand of the evidence base to help them make the decision that they think might be best for them. I hope you've enjoyed this conversation. If there are any questions that you have or other topics of interest that you'd like us to cover going forward, just leave messages underneath this video and we'll be happy to address those for you in the future. Bye for now.